YouTube channel. So we would like to thank the AAES as well as paratroopers for providing us with, frequently asked questions from their membership. We will also be taking live questions from the audience throughout the course of this hour. You can enter your questions in the comments section directly on the Facebook Live stream. And again, it's important to be aware that we're not going to be answering any personal medical questions or providing specific medical advice. So these are going to be general questions and answers session here. So for those specific types of medical questions, we encourage you to please seek advice from your doctor or medical team who has experience in parathyroid disease.
Okay, we would now like to ask our panelists to just introduce themselves. So trying to go in alphabetical order here and figuring out whose last name is first. I think that would be Dr. Silverberg.
So that's actually a first for me, with a last name starting with S. I have never been at the top of the alphabet before. So my name is Dr. Shani Silverberg. I am a professor of medicine in the Division of Endocrinology at Columbia University. I'm the medical director of the Parathyroid Center and the clinical director of the Metabolic Bone Diseases Unit.
Great, James.
Good evening. My name is James Solberg. I am Chief of Endocrine Surgery at Baylor Medicine, or Baylor College of Medicine in Houston, Texas. And yeah, my practice is full-time elective thyroid, parathyroid, and adrenal surgery, and Chief of Endocrine Surgery for the entire Baylor platform, encompassing our Veterans Hospital, our Level 1 Public Trauma Center, and our tertiary care university private hospital.
Michael?
Michael Ye from UCLA, happy to not be last. And I'm a chief of endocrine surgery at UCLA. I work with Dr. Lipitz.
And Phoebe?
Phoebe Zhang. I'm an endocrine surgeon at Houston Med. I will be joining Dr. Solberg at Baylor. So very excited to participate in this panel this evening.
All right, thank you so much, really, to all of our panel of experts for giving us your time this evening. And we'll now start by answering some questions. As a reminder, none of them will be about specific medical advice or any personal medical questions. So the first question I want to get to, which was a question that was asked on our chat ahead of time and generated a lot of comments, where there are these kind of specific criteria for which patients should be considered for parathyroidectomy, and is there actually strong data to support any of these specific indications? And what would a patient do if they don't meet any specific indications, but they have high calcium and high PTH? Should those patients still be considered for surgery? I'm going to ask Shani first as our endocrinology representative.
So the exciting hot off the presses news is that the manuscript today was completed today with the next international guidelines. So what I'm going to be talking about today is actually the current international guidelines, which came out of a consensus panel with people from all around the world in 2014. Over the last 18 months, a group of 90 people literally from all around the world, every continent. I don't think we had anyone from Antarctica represented, but really literally everywhere else, hashed out newer guidelines based on updated data, but they are not going to be terribly changed. There are some nuances, but the ones I'll talk about tonight are still going to be in effect. The first thing to mention is that it is never wrong to have surgery for primary hyperparathyroidism, whether or not a patient meets guidelines. So surgery is the only way to cure this disease. There is no magic bullet. There is no drug. There is no option for this going away if you sleep better, do more exercise, or take more supplements of whatever kind. So surgery, if a patient is interested in cure, and as people age, there are very few of the diseases associated with aging that can literally be erased from your diagnostic list, this is one that can. On a Thursday at 2 p.m., you can decide never to have it again. And surgery really is the only option for that. The place where the guidelines do come in or are more important are in patients who don't have classical symptoms of primary hyperparathyroidism. That is to say, it is well agreed everywhere that patients who have kidney stones or calcified kidneys should have surgery. There's no controversy about that. That definitely gets better. The data are fabulous. Similarly, there is no controversy about the fact that people who have the classical bone disease of primary hyperparathyroidism, which was called osteitis fibrosa cystica, a disorder we almost never see anymore. Everyone agrees that surgery should be done in all of these patients. The guidelines and criteria that people have asked about are ones that are found on evaluation of a patient who does not present with symptoms of bone disease or symptoms of kidney disease. They're not coming in saying, this is my complaint, I'm having blood in my urine, or I have a kidney stone or multiple fractures. So in those patients, these elements are actually only found on biochemical and other evaluation. The first one to mention is how high the serum calcium is. And the guideline says that anybody whose serum calcium is more than 1 milligram above the upper limit of normal should probably have surgery. Now, truth in advertising, there are no data that say that if your calcium is 11, it's okay. And if your calcium is 11.4, it's not okay. The choice of 1 milligram above normal was really just a guideline to say, if your calcium is very high, surgery really is recommended, and having the surgery will make you better in many ways. But there isn't a lot of data that says that this is a magical number, that if you are 0.1 above it, you're in terrible shape, and if you're 0.1 below it, you're in a different category altogether. The second set of guidelines has to do with the effect of excess parathyroid hormone on bones, because even if people don't have the classical old-fashioned disease, there is no question that excess PTH has a negative effect on the skeleton. And so what we have decided is that if a patient has frank osteoporosis on a DEXA scan, that should at least set off a light in their heads and in their physicians' heads saying, boy, surgical correction of the primary hyperparathyroidism should be considered seriously in this patient. And the reason for that is that our long-term data, but also all of the randomized clinical trial data, which are all very short-term, do show that after parathyroid surgery, people's bone density improves. And that improvement in bone density, we would think would be associated with a decrease in fracture risk. The other criteria for a skeletal issue comes from an interesting fact that many people don't know, and that is that unlike any fractures anywhere else in the body, vertebral fractures are not always clinically apparent. You break your hip, you break your arm, you break your leg. It's not subtle. Everyone knows that it happened. But about 30% of patients who have vertebral fractures due to osteoporosis do not know that it happened until they have an X-ray or some other film taken to look at their vertebrae. And so that is something that we recommend, because if a patient has no idea that they've had a vertebral fracture, but they actually have one on X-ray, we know that those patients will get worse unless parathyroidectomy is done. The third criterion has to do with kidney function, and that has to do with if it's impaired, we think that patients should go for surgery, even if they have no symptoms that are overt. And similarly, if an X-ray of some sort shows a kidney stone that is not clinically obvious, that is, there's a stone sitting in the kidney, but it hasn't made a person have bloody urine or pain in their flanks, those people would also benefit from surgery. The final criterion is age less than 50. And for that, the only actual data that we have comes from my group. We looked at patients who were 50 and younger and those who were over the age of 50 and looked over a 10-year period to see how many of them had evidence of worsening disease. And we found that 2/3 of the younger people did, whereas only 25% of the people over 50 did. Now, there are analogies in other diseases. So for instance, breast cancer is worse if it presents in a young person than if it presents in an older postmenopausal woman. So there is precedent for diseases behaving differently in young people. And once again, what I would remind all of our listeners is that there is nothing magical about 50. So when I see somebody who is 52 or 54 or 55 or almost anything younger than I am, I say, look, you're relatively young. You're, from an actuarial point of view, you're likely to live for a long time. This is not going to go away, and consideration of surgery makes sense.
Great, wonderful. Thank you so much for that perspective. Michael, I see you nodding your head. Can you share that your surgical perspective, how you deal with the indications?
First, want to say I really enjoyed what Dr. Silverberg said. I will admit that I don't consider a patient's chronologic age very much in the decision for surgery. As Dr. Silverberg said, I do think about the patient's life expectancy. You know, here at UCLA Hospital, we have many people who are in their 40s who have been smoking and drinking and their livers are no good, and we don't offer them surgery even though they're chronologically young. And then we have 75 and 80-year-olds who are power walking and taking care of their grandkids and so much to look forward to. And those people are going to live a long time. And so I personally think the disease course is kind of a function of how long it's going to grind away at your skeleton. You know, so I really think of physiologic age. I think of life expectancy, and a lot of the decisions based on that.
Okay, great. We'll move on to the next question. This will be for you, James. You know, some of the people who are listening, they have a diagnosis of hyperparathyroidism with their labs, and they've had some imaging, and that hasn't been able to locate a parathyroid adenoma. So what do you do when a patient has negative imaging?
Yeah, so great question. And I think the first thing that really in this topic of negative imaging is to clarify that simply because your imaging is negative, that has nothing to do with the diagnosis of primary hyperparathyroidism. It also has nothing to do with an indication for surgery, yes or no. Negative imaging is just negative imaging. It's important for the audience to recognize, and we always, all of us on the panel always emphasize this to our physicians that we work with. The diagnosis of parathyroid disease is a biochemical one based on your blood work, on your laboratory profile, and possibly on some urine analysis in constellation with that comprehensive picture of what the skeleton is looking like, as Dr. Silverberg has outlined. This imaging is a roadmap to help the surgeon identify where to start the operation. And despite all our ultra fancy scanners and 64 slice and 128 slice CTs and all the different dimensionalities associated with every scan, and ultrasounds and sestamibi scans, and even now we're getting into looking at PET scanning, still 10 to 15%, maybe we can get that number a little bit lower, but 10 to 15% of cases are going to have, quote, negative imaging. And that just means that the patient has biochemical disease. It's hiding from our scanners, and definitely illustrates the need to have an experienced surgeon take on that case. We know that surgeons who perform at least 50 or more parathyroids a year are going to have better outcomes than surgeons who are not meeting that number. And in cases where all 4 glands have to be identified, there's a possibility of ectopic location. There's possibility of multiple smaller glands that are hard to identify. That's where you really need that experienced surgeon in those cases of negative imaging. So negative imaging is just that, it's negative imaging. Doesn't mean you don't have the disease. The diagnosis is biochemical one. And the imaging is just to help us, the silly surgeons, try to create a strategy on how we're going to approach that patient operatively.
And Phoebe, negative imaging is a common reason why patients have some delay in being referred to a surgeon or have a hard time getting an operation when they have hyperparathyroidism. What do you make of this problem of sort of under-referral or patients with hyperparathyroidism not being treated enough for surgery when they would benefit?
Yeah, so this is a problem that has been sort of demonstrated across a variety of practice settings, all the way from the VA, like Dr. Sulliberg has studied, at academic medical institutions like yours with Dr. Ye, and at the Cleveland Clinic, at UAB. We've looked at it from a biochemical standpoint in terms of people who are hypercalcemic, never even get a PTH checked, and then people who are diagnosed with hyperparathyroidism never get referred. And so we've looked at it from a biochemical standpoint where they have the biochemical diagnosis. We've looked at it from administrative data, just looking at the diagnosis codes. We've looked at it through claims data, through insurance claims, and consistently we find that there is some delay or reluctance to refer patients who have hyperparathyroidism to surgery. And we're at the point where we know that the signal is really strong there. And so in the AAES, we have multiple strategies to try to address this issue. So the ESIC committee, we are partnering with a variety of primary care organizations such as the AAFP to sort of increase awareness among primary care physicians that there is this underdiagnosis and under-referral problem. Two of our crowdfunding projects for this Parathyroid Awareness Month are related to underdiagnosis and under-referral. So Dr. Sieb's project from Stanford, which is a partnership with NYU, is looking at patients that end up in the emergency room with a kidney stone and whether if they were hypercalcemic, they should get worked up for hyperparathyroidism. So she's looking into a system where they're actually going to send the patient a message through the patient portal, notifying the patient themselves that they should consider approaching their primary care physicians to work up the possibility of hyperparathyroidism. Dr. Lai's project at Georgetown is looking at why there is a delay. And so her study is more of a qualitative study where she actually is going to interview both patients and referring physicians to see what are the barriers to diagnosis and then ultimately to referral.
Okay, thank you, Phoebe. That's for the important information about some ongoing or some upcoming projects we're going to be looking into further. So I want to switch over to some questions coming directly from our live session here. And the first question is talking about autoimmune disease and hyperparathyroidism. So specifically, the question comes in as, can positive RA and anti-nuclear antibody be related to hyperparathyroidism? So let's start with Shani and get your input on that.
No, it's very simple. There's really nothing else to discuss. They can coexist in the same person. And one of the things that's important to know is that from a demographic point of view, primary hyperparathyroidism is a disease of women. And it's a disease of women in middle years. RA is also a disease of women and a disease of women in middle years. Lupus is a disease of women, not so much in middle years necessarily, but so these things certainly can coexist, but they are not causally related in any way.
Okay, all right, great. I think that's very clear and to the point. And yeah, and certainly autoimmune disease is common in females, and so is parathyroid disease, but they don't have a direct relationship with one another. So I'll ask Shani another question from our Facebook group. How do patients maintain a continued continuity of care when a hyperplasia diagnosis is determined after a subtotal parathyroidectomy and the patients are having continued symptoms? So I think we'll start with you, Shani, and then we'll get a surgeon perspective answer after you.
Great. So the first question is whether or not after their subtotal parathyroidectomy, if they are biochemically cured, even if they have a hyperplasia diagnosis. So if they're cured, and they need to be followed just as other patients do to make sure that nothing else comes up over time. And if they are biochemically cured, any persistent or residual symptoms, clinical symptoms that the patient has, are unlikely to be causally related to the parathyroid disease. So again, it's really important to work with your practitioners to appropriately attribute symptoms to findings. So if you have a patient, and this sometimes happens, for instance, with patients who come in complaining of excessive fatigue. If they have excessive fatigue, they have a parathyroidectomy, they are biochemically cured, whether it's from an adenoma or hyperplasia, and they are still extremely tired, they are just extremely tired, or there's another reason. But you can't blame the extreme fatigue on a biochemical finding which is no longer there. So if the patient is cured and there are continued symptoms, they have to find another reason for them. If the patient is not cured after a subtotal parathyroidectomy, then the question comes up, should their physicians be thinking about a reoperation? Now, reoperation is never something that should be never an emergency, never, and should not be undertaken quickly. And the bar, at least, I'm very interested to hear the surgical perspective, but my bar is higher because I know that it's always harder to cure at a second operation. So I would then follow the patient and see if they really have a good reason to consider another surgical procedure. And if the answer is yes, then that should be done at the appropriate time down the road once they're cured in the light of day. And I think I'll stop here and get the surgeon's input.
Absolutely. So I'll open that up to any or all the surgeons if you want to add your input on, how to manage this type of situation where patients are still symptomatic after a subtotal parathyroidectomy.
I would tend to agree with Dr. Silverberg. And the first note, just to echo a note of caution, that we can't blame everything on the parathyroids. And it's really it's a question of attribution, right? So a lot of the complaints that people with hyperparathyroidism have can be caused by other things, and if I understand the question, doing a good operation for hyperplasia is hard. It's what I call the Goldilocks operation, right? Because you can't leave too much parathyroid, you can't have too little, it's got to be just right. And we like to aim for a final PTH in the operating, at the end of a case, we like that PTH to be in the low double digits, right? Well, as low as 11, as high as 35, 40, not much higher than that. And usually those people are going to have a long-term cure. And if the labs kind of stay in that range with a normal calcium and acceptable PTH level, and post-op, we accept a little bit more fluctuation in the PTH level. As long as the calcium level is okay post-op, generally that's a good result. So I would caution people not to attribute everything to the parathyroids.
Yeah, I agree with Dr. Silverberg and Dr. Ye there. I think one common point of confusion is the patient who follows up with their team, their care team, and the repeating PTHs 1 or 2 or 3 months after the surgery, and the calcium and the PTH, and the calcium is stone cold normal, and that PTH is up, even though the operation had a PTH, did intraoperative PTH monitoring. That final PTH was between 10 and 35 or 40, just as Dr. Ye described. And we know that around half, sometimes, of cases, that PTH may fluctuate and rise a little bit in that first sort of 6 months to even sometimes 12 months, depending on that patient's skeletal manifestations, what their bones are doing, what their vitamin D status is doing. But that calcium is going to stay very normal. And it's important to emphasize that this can become a very big point of objection from inexperienced referring practitioners, a big point of worry amongst patients. But your experienced care team will know, hey, listen, the calcium is normal. You have biochemical cure. You had a good initial operation. We expect a little fluctuation for that first 6 months to even 12 months. It happens, but you're going to do well. And so that biochemical cure of eukalcemia at 6 months, or normal calcium level at 6 months, is what we strive for. As the panel has said, there's a variety of different causes that are a variety of different symptoms that are associated with parathyroid disease. But if you're biochemically fixed, you've been fixed. And so I think that maybe some of the other folks can talk about, it's quite common for us to see patients or get a phone call of the PTH a little bit higher than expected in that first 6 months, but the calcium is stone cold normal. And really, it's important to reassure the patients, you're going to do well. You're going to do well.
Yeah, Phoebe, I'd like to ask you actually, what about the opposite problem? What about hypoparathyroidism? That was a question that came in over Facebook. How often do we see hypoparathyroidism after a parathyroidectomy? How can we prevent it? And how can we manage that?
Yeah, so obviously hypoparathyroidism is one of the risks that we warn our patients on, but fortunately in experienced hands, it's quite rare. Part of that is due to the disease. So 85% of the time, patients just have single gland disease. And if there is minimal to no manipulation of the remaining glands, then the risk of hypoparathyroidism in those patients is quite low. Where we start getting into a little bit more trouble is in the patients with multi-gland disease, where we need to be doing for gland exploration. And in those patients, there are sort of some backup maneuvers that we might have at certain institutions. So if you end up taking out a little bit of too much parathyroid tissue, you can always have the possibility of reimplanting some, or alternatively, if you're at an institution where they do cryopreservation, you can actually freeze and bank some of the parathyroid tissue so that it's kind of like a backup insurance policy. If the patient ends up being hypopara, you can actually bring the patient back and reimplant that tissue back in their forearm. And that tissue is generally viable for up to a year in the bank.
Okay, thanks, Phoebe. Shawnee, I'd like to ask you another question that came in over Facebook about secondary hyperparathyroidism. This is something that a lot of our patients kind of struggle to come to the diagnosis, that the calcium is normal and the PTH is elevated in particular, and they're struggling to figure out with their doctor, do they have primary hyperparathyroidism and they need surgery, or do they have secondary hyperparathyroidism and they don't need surgery? How do you approach those patients in terms of the diagnosis and then the treatment?
So if the calcium is there are actually two groups of patients that we can think of. The first is people who have not had surgery and are actually in the process of getting a diagnosis. And the second are the group of patients that Dr. Silberberg was talking about. They're postoperative and they may have high PTH. So to step back, in primary hyperparathyroidism, the primary problem is the parathyroid gland. It is not functioning correctly. It is diseased. It is overactive. Secondary hyperparathyroidism is the situation in which the PTH level is high, but it is high because of something else going on in the body. And in fact, not only is the parathyroid not diseased, it is doing its job. It is working overtime to correct an abnormality elsewhere in the body. The most common causes for secondary hyperparathyroidism are either that there's too little calcium coming in or there's too much going out. Under the too little coming in, it can be because an individual has a very limited dietary calcium and doesn't take supplements. Another cause, and the most common cause that we see, are patients who are vitamin D deficient. In those patients, because vitamin D's action is to allow calcium to cross the wall of the intestine into the bloodstream. And so you can have a vitamin D deficient patient who literally drinks milk till the cows come home, and yet the calcium does not get absorbed from their intestinal tract and instead goes out in their bowel movements. Those patients classically have high PTH levels, but do not have a diseased parathyroid. It's just working so hard to get extra calcium to provide for the body's needs. Similarly, patients who are kidney stone formers, not primary hyperpara stone formers, but people who just have a leak in their kidney and their calcium leaks out. Those people also have a high PTH, which is secondary. And that is, again, working to get extra calcium because the calcium coming in may be fine, but too much is going out in the urine. So what we advocate is that if someone has a high PTH and a normal calcium, the first thing to do is to dot the I's and cross the T's to make sure that all the causes for secondary hyperparathyroidism have been evaluated and eliminated before considering a diagnosis, for instance, of normal calcemic primary hyperpara. On the other side, what Dr. Suleberg was talking about is postoperatively, and the high PTH that is seen in up to 40% of patients in the first postoperative year is due to a secondary hyperparathyroidism. And that, I would say, the surgeons can help with because they are the ones who see the patients after surgery, but you as patients can also advocate for yourselves. So if you have a parathyroidectomy and after surgery, your doctor doesn't tell you to take calcium, or if you had a very low vitamin D level prior to surgery and they were worried about giving you vitamin D because they didn't want your calcium to become more elevated. If those things are not corrected after surgery, your parathyroid hormone will never normalize. So the causes of secondary hyperparathyroidism need to be treated in order to satisfy the parathyroid gland.
Thank you, Shani. That's a very detailed explanation. Also, I think that some people had some questions about, can you have both primary and secondary? I know that answer is yes, and just want to see you're nodding your head as well that you can have both, and so you have to treat both issues. If anybody wants to kind of speak to that a little bit.
Yeah, so Dr. Silverberg's answer is so thorough and so intellectual, but maybe the simple version is that, once again, to summarize, primary hyperparathyroidism, there is something fundamentally wrong with the parathyroid gland, usually a benign tumor. Secondary means the parathyroids are behaving normally. They are responding normally to an external force. Yeah? And one way that's easy to distinguish the two is in primary, if the patient has high calcium, then it's likely primary. Very likely, not always, but almost all the time. So that sometimes helps to distinguish the two. And if the question is, can a patient have both? Yes. Those patients typically will have a high calcium and at the same time, vitamin D deficiency and or some degree of loss of kidney function, and they can have both.
All right. I'm going to move over to some surgery-related questions. One question that has come in is, does the size of the parathyroid tumor have an effect on how severe the parathyroid disease is? And follow-up of that is excuse me, let me repeat that. So does the size of the parathyroid tumor relate to the length of time that it has existed in the patient? So is bigger necessarily, does that mean an older or longer case of parathyroid disease? And follow that up with, how long after successful parathyroid surgery would you expect the body to go back to normal? So I think what they're getting at is how long after surgery until they actually start feeling better. So let's go ahead and have Michael continue on, and we'll hear from the other surgeons as well.
Oh, I've talked a little too much. I'm gonna pass it on to Phoebe.
Okay, sounds good.
So I guess the question is, does size matter? I think all of us on the panel have seen that there are definitely some glands that are just so small and yet so hypercellular. So particularly like patients that have hyperplasia due to lithium, I've seen that the glands are not necessarily very large, but all the cells are just so metabolically active and packed in there. So I would say that the size doesn't necessarily always correlate with the severity of the biochemical disease. So that's been my experience, but I'm curious to hear what other people on the panel have been have experienced. The second question about when am I going to feel better really depends on the symptoms. And so if you look through the Paratroopers website, one of the things that gets, or the Facebook group, one of the things that gets posted the most is how fast symptoms resolve after parathyroid surgery. And I would say that the things that resolve faster are particularly things related to bone pain. If we're looking to see things in terms of effects on the bone mineral density, that's something that took a long time for your bones to get to that state and will take a long time for your bones to sort of recover from that state. And so that's really a years long process. And similarly for neuropsychiatric symptoms, generally what we see is that the neuropsychiatric symptoms takes weeks, if not months, to start improving.
James,
Yeah, and I just follow up. We've been doing some routine neurocognitive testing in patients pre-post, and it's quite variable. We're seeing resolution on the neurocognitive tests with improved cognitive function in some patients right at their 2 or 3 week post-op follow-up. In other patients, it's taken 3 to 6 months. And it's been very variable. We've got small numbers so far. We're going to be continuing to do this work and hope to have some large data set to have some patient-specific predictors, hopefully in probably a couple of years. I don't find any linear relationship between size of adenoma, degree of symptomatology, and length of time that the patients have had it. I think it's all over the map. And it's just one of the fascinating things about the disease.
Okay, I'm going to address one more surgical question to you, James. Do we need intraoperative recurrent laryngeal nerve monitoring in parathyroid surgery? I knew you're going to smile to hear this one.
So I think this is, so here's what I would say. For reoperative surgery, absolutely, the answer is yes. And I think for index surgery, I think the most important thing is an experienced surgeon. And if that experienced surgeon chooses to use intraoperative nerve monitoring, then so be it. And if that experienced surgeon has good outcomes and doesn't use nerve monitoring, then I think that's also okay. But I think number one is that you have an experienced surgeon. That experienced surgeon is going to feel most comfortable operating with her or his setup that is preferred. And that's number one, no question about it. Reoperative surgery, whole different ballgame. And personally, I'll just go out on a limb and say, whenever I do a re-op, I have to have nerve monitoring for it. It's just an exceptionally treacherous operation, and that's just me. That's just me. That's all I'll say.
Yeah, and I would just echo that the intraoperative nerve monitoring is a tool, but really the most important thing is the surgeon who's doing the operation. So the next question I'd like to get to, and this is one that I've seen commonly on web pages online, is what is a normal calcium? And is it true that patients should not have a calcium, let's say above 10, if they're over age 40? Is it true that anybody with a calcium over 10, that is abnormal? Is there any data to support that? Shawnee, can you address that?
Yeah, so normal ranges for anything are obtained by people in the hospital, the lab, wherever it is, having people of lots of different ages come in and donate their blood for the purposes of obtaining a range of normal. And that's because what's normal for me may not be normal for James or for Phoebe. So what we all have is our own normal. So there are people for whom their normal range all of their life may have been in the high 8s, and for them to be in the 10s is distinctly abnormal. But for the most part, it's not an age correlation. There is an age correlation with parathyroid hormone level, on the other hand, so that the normal ranges for PTH, the upper ranges of normal for PTH, are not particularly normal for somebody who's 30 years old. And that is because the kidney function in everybody, in all normal people, deteriorates slightly with advancing age. And as a result, the body has to work harder for the kidney to produce vitamin D, and parathyroid hormone has to work harder to get that to happen. So somebody with a PTH of 65 who's 24 is likely to have that PTH is likely to be high. On the other hand, if someone in their pediatric when they went to their pediatrician had a calcium of 10, then they're likely to live in the 10s all the time. So I actually would suggest that it's not the calcium that shouldn't be high, but probably the PTH shouldn't be high in patients who are young.
Okay, great. And just to kind of clarify and drive that point home, is there anybody in the panel that would say that, let's say a patient has a calcium of 10.0 or 10.1 and a PTH of 25, and they are 60 years old? Would anybody in the panel consider that to be biochemically suspicious for hyperparathyroidism? Okay, sounds like nobody. Okay, great. So we'll move. Yep, please.
Just real quick. Yeah, this is a question we started to get just recently, like a couple of years ago, 3-4 years ago, whether or not calcium is a function of age. It's not. I don't think there's any data to support this. And I just want to caution, it's a moment to caution everybody who's tuning in about stuff that just gets made up and put on websites. And, the people who are on this panel are a bunch of school teachers. We've got nothing to sell you. We have no reason to deceive you. So there's just not. And please beware of people's motives when they try to make levels that are normal into something that are abnormal. They're just not. And I just want to highlight just a real brief concept that we've kind of been dancing around, which is something called a set point. And Dr. Silverberg mentioned this, as each person has their own set point. And normal parathyroids have a set point. It's like the temperature on your thermostat. What temperature are you setting your house at? Different people can have different set points. And parathyroid tumors, big or small, is not important. They each have their individual set point, and that's what's going to make your calcium level.
Very good point to drive home. Okay, we have I'll split this one. We have a kind of biochemical question and then another surgical question. So I'll address this one to Shani. Is alkaline phosphate commonly elevated with hyperparathyroidism or high PTH levels?
Yeah, just really briefly, it's actually alkaline phosphatase. It's an enzyme, and it's a bone enzyme. So many people who have high PTHs will also have high alkaline phosphatase. It doesn't have to be, but it can be related.
Okay, all right. Quick and to the point. And another question that comes in is, what makes a surgeon experienced enough to perform a reoperation on parathyroids? How much experience is needed? So Phoebe, let me start with you.
Okay, so I think it really has to do with how much overall parathyroid surgery that the surgeon does. So it's a combination too, right? It's a combination of annual volume and cumulative volume. But then there's also this aspect of individualized risk calculation, right? Like whenever we're doing surgery, we're trying to figure out, is this patient really going to benefit from the surgery? And is that worth the risk of surgery? And so in a reoperative setting, it's really challenging because there's so many pieces of information we have to put back together, right? Like, what was the biochemical diagnosis at the initial surgery? Did the patient have multi-gland disease, or why did the surgery fail? So the first things we usually do are to try to track down the operative note and the pathology report. I clearly remember Dr. Ye telling me when I was a fellow at UCLA that surgeons lie, but the path report does not. And so we're really trying to piece together what happened at that first surgery, and so that we know what the risks are going in the second time, right? And reoperative surgery is not the same in every patient, because sometimes if you've only had one side of the neck dissected, that's really actually not reoperative surgery, right? When you go back and your target is on the other side, that's almost a completely virgin plane that is no increased risk compared to first-time surgery. So there are a lot of different components that experienced surgeons try to put together to try to calculate a patient's individualized risk about whether it's worthwhile to go back or not. And then echoing Dr. Silverberg's point is the first step is to reconfirm the diagnosis, right? We go back to step one and we decide, does this patient actually biochemically have hyperparathyroidism? And then we go from there.
Great, thank you, Phoebe. And just a clarification, I see a comment in the chat about our discussion about, calcium of 10, is that normal? To clarify, we're talking about calciums that are technically, that look normal in the range of the lab, particularly calcium of, 10.0, 10.1. If a patient has a high calcium, 10.5, 10.9, even if the PTH is normal, that certainly may be normal hormonal hyperparathyroidism, right, where the PTH is inappropriately normal given an elevated calcium. So those patients, we would all agree, very likely may have hyperparathyroidism. But the patients we were referring to have a calcium that's not 10.5 or 10.9, it's really like 10.0, which is in the normal range of our lab.
Absolutely. And along those lines, there's another question that comes in is asking, what sort of training do general practitioners get about hyperparathyroidism? I think this is an important question. It seems many primary care physicians don't see a pattern of high blood calcium readings to be a danger signal. And I would just like to start by saying that part of the awareness is the responsibility of us as specialists, as endocrine surgeons and as endocrinologists who deal with a lot of parathyroid disease, because our colleagues in primary care may underestimate or may not know the seriousness of having a high calcium level. A high calcium level, by definition, is not a normal finding. So with that, let's see, we'll go back to James to see what his input is on this.
Yeah, so thank you, Courtney. I totally agree. The onus, is on us as specialists and experts in the field to, do the education and outreach. I know we are constantly, on the schedule for lectures for not only our students at our academic centers, but our residents in the medical specialties, internal medicine, family practice, even, especially for women, many women's OBGYNs are their primary care physicians. So we really get out and try to get the word out by doing invited talks and speaking engagements. And I know all of us on the panel do those things, and colleagues across the country do those things. But certainly, for specialists in the field, this is what we do day in and day out. And so we're sort of at the bottom end of a funnel, and everything else is sort of running around. And so for us, we sort of have that benefit of the retrospectoscope. But I think, we do as well we can. I think we have some excellent crowdfunding proposals. Phoebe, you can speak to that again, maybe, to raise awareness and patient-centered awareness of what's the effectiveness of patient-generated notifications to request that follow-up for an elevated calcium. One thing I just want to touch on real quick on the re-op, if I could, is what Phoebe had described, and that is the degree of re-op. So one reason we've looked at this with the MD Anderson group, if you constantly and all you do are 4-gland explorations, you're going to have a failure. If all you do all the time are bilateral neck explorations, at some point, we're all human, you're not going to have a 100% cure rate. The reoperations that are generated from bilateral neck explorations have significantly higher complication rate, difficulty in curing in revisional surgery, and complication rates for those revisional surgeries are real. Permanent nerve damage, bleeding requiring takebacks to the operating room. It's just an exponentially, we're all familiar with exponential growth now because of COVID, but it is absolutely an exponentially more difficult operation when you have routine performance of bilateral neck explorations across the board. So it's very important. I often get that patients say, I've read this on this website, it has to be all 4 glands every time. And the answer to that is it has to be an operation done by an experienced surgeon and done the right way with a high cure rate. But there are a variety of different ways to, quote, skin the cat. So multiple different ways to get that operation done safely and effectively with a high cure rate. I'll just stop right there.
Thank you, James. Very well said. Before we're out of time, just a couple more questions from our group of patients. Thanks so much for your participation. Michael, there are patients who are struggling with a diagnosis of both FHH and primary hyperparathyroidism. Have you seen that coexist, and how do you tease those things apart?
So can you have both FHH and primary hyperparathyroidism? Yes. It's really, really rare, right? So FHH affects 1 in 73,000 humans. Primary hyperparathyroidism affects 1 in 400 women and 1 in 1,200 men. So you multiply those together, and in my career, I may have seen 2 or 3. Our group will evaluate about 1,000 patients per year with this. So it's pretty uncommon. How do we evaluate them? Well, we have had one patient who had all these clear records. Everybody in her family had high calcium, and everybody in her family had low urine calcium. And then one day, she started to get high urine calcium, and her bones started to deteriorate. So we did an operation on her, and then in her, there was localization for one parathyroid tumor, and we removed that parathyroid gland. And then she went back to looking at like everybody else in her family. She looked like her urine calcium went down again. Her blood calcium came down, but still was higher than normal because she's got that gene. The gene just gives her a calcium set point that's different from the average human. So a few times we've had clear evidence of this, but there's a saying in medicine, when you hear hoofbeats, think horses and not zebras. And the coincidence of those two diagnoses would be an extreme zebra. So you've got to think about what's likely to be the diagnosis.
Yeah, Michael, I totally agree. We just saw that question pop up on the channel, and literally last week had a family come in who's sequenced positive for the gene. And just as you said, exceptionally rare, but we know it's going to happen. But you got to sequence the genes. You have to have the proper diagnosis, but they can, in rare instances, coexist.
I'd just like to add one thing that we also have a family that's similar to yours, Michael, and we should probably get together and maybe put them together. But what I would say for the listeners, a much more common explanation for the biochemical picture that may be confused with FHH and primary hyperparathyroidism is a patient with garden variety hypercalcemic primary hyperpara who has vitamin D deficiency, because the parathyroid adenomas are responsive to what's going on in their neighborhood. And so the urinary calcium level will go down, and some people have really spectacular kidneys that hold on to every milligram of calcium so that their urinary calcium gets down into the range of FHH. And then when their vitamin D is treated, or their vitamin D is repleted, then they look like hyperpara. And so somebody might get a diagnosis that says FHH plus primary hyperpara, and it may just have been that they happen to have had vitamin D deficiency instead. So anybody who doesn't have a calcium sensing receptor abnormality, like Michael and James said, isn't the zebra.
Okay, great. So 2 more questions, and then we'll be out of time. Phoebe, there's a question about expectations about voice recovery. How long does it take your voice to return to normal after parathyroidectomy?
Yeah, sometimes that depends on multiple factors. So one, there's often a little bit of voice scratchiness just from the intubation during surgery. And so typically if it's that, it should resolve in about a day or so. If you are really dealing with a nerve injury, it depends on whether the nerve injury is a stretch injury or a real transection, a real permanent injury. And so if it is a stretch, it's variable. It could come back as soon as a week or 2. It could be several weeks. If it's a transection, sometimes patients can actually compensate remarkably well, even after transection or permanent injury, but that process does take several months or several years. And I would say that in the vast majority of those situations, we probably wouldn't even wait that long. We probably would try to refer the patient for to a voice specialist much earlier than that.
Okay, thanks, Phoebe. And then our last question, which will be for Shawnee, and this is something that we are seeing more and more in our patients, is to what degree do medications for osteoporosis, like Prolia, like Fosamax, make it more difficult to diagnose hyperparathyroidism biochemically?
So Fosamax really isn't a problem, but denosumab or Prolia is, and the reason for that is that Prolia is so good at stopping bone breakdown that if a patient is not taking enough calcium in the form of supplements or their dietary intake, their parathyroid will secrete more, secondary hyperparathyroidism that we were talking about before, to try to get more calcium out of the bones, which it's incapable of doing. The caveat here, so I never measure PTH in people who are on denosumab because it's always abnormal and it makes everyone crazy. The caveat here is that it should not be a difficult differential diagnosis because the calcium should be normal. So if the calcium is normal and the PTH is high, you're back to figuring out what is the cause of secondary hyperpara. And in someone on denosumab, the answer is denosumab. If the calcium is high and the PTH is high in somebody who is on a medicine for osteoporosis, the doctor should have made the diagnosis of primary hyperparathyroidism, sent the patient to surgery, their bone density would get better, and then they would not need the Fosamax or the denosumab.
Okay, well, we are out of time. I think there's so many interesting aspects of hyperparathyroidism that we really could just keep on going. But I really want to thank the panel for all of your time, Courtney for co-moderating. Thank you so much to all of our participants, our patients from the paratroopers for engaging with us. We really enjoy having these events with all of you.
I want to put a last plug in for the crowdfunding project. So we have 3 excellent projects. Please check them out on the website. I think Emily's going to put a link in the chat in the comment section. So please check out those projects and help us figure out this problem of underdiagnosis and under-referral.
Yes, I think that's very important research to be undertaken. And so I just want to thank everyone who served on the panel, thank the paratroopers for their involvement and participation. We had some excellent questions this evening. And as a reminder, this session was recorded and it's going to be available on the AAES Facebook page and on the AAES YouTube channel. So for more helpful information for patients, please be sure to visit the AAS patient education website. And so we're going to post that on the Facebook page as well so that you all have access to that. And with that, I would like to say thank you to everyone, and I hope this was a informative session for all involved and an educational one. And good night, everyone.
Good night.
Thank you all.